Hello and welcome back to The Halfway Point. General practice has never worked more collaboratively than it does today. Increasingly, practices are partnering with external organisations to deliver a wide range of NHS services, from physiotherapy and podiatry to advanced practice nursing and other specialist services. These partnerships can bring enormous benefits for patients, improve access to care and help practices make the best use of their workforce. But with collaboration comes responsibility. Who is responsible for the clinical governance? How do practices ensure services remain safe and effective? And what should practice managers be looking for before working with a third-party provider? So to help me answer these questions, I'm delighted to be joined by Catherine Bird, who's a Director of Clinical Governance, Quality and Safety at Promni Health. Catherine leads on ensuring services are safe, effective and patient-centred throughout robust clinical governance, continuous quality improvement and regulatory compliance. So whether your practice is already working with external providers or you're considering doing so in the near future, today's conversation is about understanding how governance should underpin every successful partnership. So to get started, Catherine, welcome to The Halfway Point. And can you tell us a little bit about yourself and your role at Promni Health?
Yeah, sure. Thanks for the introduction, Ben. So I'm Director of Clinical Governance, Quality and Safety at Promni Health, also previously known as Primary Care Physio. I am a physiotherapist by background, but my role is to oversee the clinical governance, patient safety, all the safe practice, clinical practice, I should say, that we provide at Promni Health. I guess clinical governance isn't the most glamorous subject, but as we know, it's fundamental in ensuring the safety of our patients and the care that we provide. Promni Health delivers care to over 200 PCNs nationwide. We're a clinical service provider, so we're not a locum agency. We actually deliver the whole package. So we have a really full structured management team. We provide the clinical governance, the recruitment processes, the HR processes, with a full package basically at the delivery of care.
Okay. With that approach, and how does your role of the director, on a day-to-day basis, kind of what are you seeing across general practice and how does your role fit into that?
Yeah, so my role predominantly, I think probably if you're a bit geeky like me and you understand about clinical governance, it goes back to the NHS fundamental standards of clinical governance, which are the 7 pillars. So it's around insurance that we're risk managing. We're providing understanding of patient experience, so compliments, complaints. So on a daily basis, I am interacting with all of the leads predominantly, understanding what's going on the ground in all our PCNs and the practices. I follow through the whole journey of the implementation of the first contact practitioner or mental health practitioner and ensure that the recruitment stages are followed through, that we're inducting the clinician appropriately, and that we're supporting the clinician through their training, we're maintaining the standards. So it goes as far as then the whole cycle, auditing our standards, making sure that our quality is there and we're providing, again, that safe care to our patients. So it's all linked to CQC standards, because I know that's a bit of a hot topic.
Yeah, I was just going to say that.
So we work within all of the CQC standards. So one of my main jobs is to obviously understand what all of the 34 quality care standards, as they were, and everything that we deliver aligns with CQC and those standards that as practice managers that you have to ensure as well. So it's almost like we co-work with you in general practice. So it's like a shared governance accountability, if you like.
Yeah, I like that, and especially where you've said it's not like a recruitment centre model, as you said, like you're or an agency, you're putting the staff in, taking responsibility, and everything that goes alongside that. And that's very similar to what we're doing at LPM. So seeing more practices working with like external providers like yourselves. You talked about there's 200 practices and PCNs. What's driving that change as opposed to, say, the dare I say traditional recruitment model of doing it in-house?
Yeah. I mean, the advantages, I suppose, of external organisations providing the care are around the recruitment. So it's as a national organisation, we've got a national recruitment. So it's quite flexible, and the scalability of it's really structured. So we've got a huge pool of staff, across the country. The learning from each other is massive. We have, for example, of one of our highest risk is around injection therapy, medical prescribing. Yeah, so we have those kind of groups where we can all interact with each other, we can all learn from each other. I think the workforce is probably one of the best things about companies like ourselves providing into primary care. I think the other things is around the sickness, the maternity, it's easy to flex in and out of that rather than just recruit locally. I think having that ability to draw from a different area, maternity leaves. So definitely for recruitment, I think definitely for the learning, shared learning, and also career development. So having that specialist, like having that, because we're a specialist provider, we're not just a local provider. You have that ability to kind of progress into injection therapy or non-medical prescribing if you want. You have the ability to contact myself as Director of Clinical Governance. We have a Chief Medical Officer, which who's a GP that gives specialist advice to all of our people that we recruit as well. So I think there's lots of advantages of having a third party provider. And I haven't really touched on the governance yet. So obviously having all of that assurance around governance
Yeah.
that's probably one of the comments that we have from practices saying thank you for taking the governance office. So if there's a complaint, if there's a claim, if there's a serious incident, all of that we manage in-house, which is
that's really interesting, because I was thinking about one of the things that seem to be in recent years is practices can be very silo, I guess is the right word, in that you don't know what you don't know. And we all operate under the same contracts and everything like that. But just seeing it from a national picture, you've now got 200 practices or PCNs feeding into your processes. So your clinical governance and everything is updated. It's fresh from the ground. You're getting lots of perspectives. Whereas when a practice is kind of on their own, as I said, you only know what you know, and that can be a real barrier. And it's a lot of pressure as well on the management team, not just the PM, but the partners and the business owners as well. So I think that's a really good segue then into the governance that you mentioned there. And I think kind of just starting that then is looking at the responsibility side of it. So when a practice commissions or works with a provider like yourselves, where does the governance responsibility sit? I mean, that's quite a broad question to start with, but let's start there. And yeah, where do you see the governance responsibility sitting?
I truly think it's a shared accountability for governance. It has to be, because obviously we're responsible for our clinician. And I say that when we do complaint management, when we're doing NHS resolutions work, we are responsible for our clinician. But at the same time, the practice is responsible for their patients. So although they're our patients,
True.
so it has to be a culture of shared accountability, 100%. So yeah, I think touching on what you were saying about having a national organisation which has this shared accountability is such a benefit, because yes, we're just predominantly managing FCPs. We also manage mental health nurses, OTs and podiatrists. On our FCPs, which are currently our largest workforce, if there's an incident, for example, I'll be managing the NHS resolutions claim, but it's probably going to be more frequent than a practice will manage it. Therefore, the skill set that I'm managing that level at is shared then. So I'm often giving guidance to practices around the best way to do it, gold standard. Yeah, and we definitely manage the complaints process in joint as well. So going back to the accountability, I mean, yeah, it just has to be shared, because we can't manage it all independently either, because as not a remote service, but somebody that, for me, I'm not in those practices daily. I'm not seeing those clinicians, those patients. So we rely really heavily on that collaboration, I suppose. And I always think the better the relationships are between the local clinician and the PCN and their team, the more successful the integration and the collaboration is.
I couldn't agree more. And you made some really good point there around the complaint. Just thinking about the first time I had one from NHS resolutions, I was panicking, and it's really daunting. It's the top dogs complaining at you, or about your service, and you take pride in it, so you take it personally. But you make a good point, for you and the team, it's more regular. Let's be honest, we don't want a complaint. No one wants a complaint. But what you're getting at is you've dealt with it before. So, you can take that sting off the practice, right? Don't panic. You've got to do this, this, and this, but this is the time frame. Take the edge off the pressure, I guess, on that. And I suppose likewise that can cover over to whether it's a clinical complaint, a patient complaint, or in any other area, especially around with the governance side. You've got that experience of doing it at scale. So it becomes more regular for you rather than the irregularity of the practice, then running the risk that they get the procedure side of it wrong, or something is out of place, or not, a document's not submitted when it should be, and so on. So, and that can then delay the impact. So I think it's a really good point you mentioned there about where you're doing it at scale. That comes almost naturally.
And it also, on the flip side of that, it's really good in terms of like what's working well, because we can often focus on what's not working so well. The gathering all the compliment stuff as well, and the good practice stuff. As we know in primary care, the highest risk is usually around missed fractures, cauda equinas, missed tumours, but actually the spotting of those and the being able to identify the red flags, all of that positive stuff is also a really good joined collaborative way of working. So sharing how that's worked, sharing how, for example, imaging, where the success stories through imaging have worked, how we've cutting imaging, how I can give an example of a recent audit done around re-return rate. So obviously in primary care, if you're a first contact practitioner or clinician, don't want all of it's how do we measure that those patients you're seeing today are not going to come back next week?
Yeah.
And that's a really difficult statistic to do without doing a lot of deep dive analysis. But we've done a lot of that lately. And actually only 4% of a snapshot that we saw came back to see the GP within 6 months, I think it was. And 8% came back to see for a follow-up for the FCP. Those kind of stats, and then redesigning that in a different area of the country, so we have the ability to sort of scale that across, and those kind of good work stats which improve, and we're going into quality improvement now, I guess, as well as governance. That's what I love about this job, is that you can kind of change the I don't want to say the bad into the good, but the learning, because the learning loop is so critical for governance. And I'm a huge advocate for embedding our learning into practice and how we measure that.
What could a day of learning mean for you and your team? Join primary care leaders on Thursday the 10th of September in Preston for a conference packed with practical sessions and workshops on a range of key areas, including CQC, finance and premises. Outstanding practices aren't built by one person. Instead, they are built by teams working together, supporting one another and leading with confidence. Whether you're an experienced primary care manager, a deputy PM, business manager, GP partner, or an aspiring leader, this is your opportunity to come and spend the day with like-minded colleagues. Together, you'll be able to learn from our experienced speakers and suppliers whilst discovering practical solutions to the challenges every practice is facing today. So for more information and to secure your place, please visit locumpm.co.uk. We look forward to seeing you there. Yeah, I'll come back to the governance, but thank you for bringing that up, because you're right. We often focus on the negatives. They seem to take more time out of the day and they worry us. But, if you take those statistics, that 4%, 96% didn't come back to see a GP, or the 8%. So 92 didn't come back to see, that's huge. That's really big numbers there. And especially at the scale you're working at. Going back to the governance then, what I was going to say is, what governance framework should be in place before a service begins. So I'm a new practice. I've come to you guys, and we're going to go down the FCP route. Where do we start? What do we need to put in place to begin with?
I mean, it's quite broad.
Yeah. I was going to say we got like 20 minutes.
Yeah,
it's a good point.
So it starts with recruitment, doesn't it? Safe recruitment. You can cross-reference CQC standards throughout the whole of the implementation of an FCP service. So it's really thinking about going from that recruitment to ensuring you've got staff that are trained appropriately. They're ticking all the boxes. I know in FCP world at the moment, there's a lot around, they have to have a certain amount of experience. So going from recruitment, I guess, and another part is around the induction, which is a huge part of clinical governance framework for us at the moment, because you can evidence an awful lot through the induction process. And I always say if the induction is strong, then the whole of the implementation of the FCP will be strong. So
Okay.
that goes back to policies, ensuring
Yeah.
the FCP understands the SOPs, the clinical procedures around something like imaging or referral on for scans or whatever it might be locally, red flags. And then we're going into the realms of documentation audits, making sure that we are consenting, we're screening, always risk assessing. So I know I've touched on our highest risks, but ensuring our risk registers are in place and we've got shared risk assessments with the practice, because we have to remember, as a third party in primary care, you are sharing governance. So working together at the start of any relationship, but at that very start of working together is getting it right. And if you've got it right in those first 3 to 6 months, then the staff members are going to feel supported. We're going to feel secure. But it's from then, it's ongoing. So it can't just be the implementation. It's for the supervision. Our structure of supervision, for example, in clinical practice that we work in is very, very robust, depending on how skilled the FCP is, because obviously that will range, and also their skills will range, whether they're injection therapists, non-medical prescribers, 5 years qualified, 10 years qualified, it'll vary. I mean, I could go on, Ben, but touching on audit is really important for me, because
Yes.
whatever you say you're doing through your policies, procedures, and SOPs, you need to be able to evidence, as we know with CQC.
Yeah, I think the takeaway I took from that was the induction, that putting the time in, putting that energy in, that effort in, rather than, we've recruited for a third party, they're starting on Monday, off you go. What you're saying is actually, no, you need to put more time in than that. Invest in the process as well as the persons, the people, the individuals. And then once you've got, you've got that first 3 months established, then you've set that framework. So then it will tick over on that basis, rather than say a rush, disorganized, chaotic. And that is hard to do, especially when you're recruiting at short notice or you're restructuring the organization. It is a hard ask, I think, but I think you've highlighted the importance of recognizing that.
And also coming back to IG and GDPR and making sure data protection, systems are really important, like with anything, having robust systems in place. Like I know we've commissioned a Gilliotine net to do ours, which a lot of practices in general practice, you don't have to have that system, but having a system, and I didn't touch on mandatory training obviously, but all of those clinical skills, basic life support, everything to do with mandatory training, if it's in the system, then it flags it a year later. Having the processes, so it's not a single point of failure basically. So
and equally you can evidence that, as you said,
absolutely.
Here's their certificates, here's their Agilio access. So working in partnership then, where does something like a service level agreement sit between a practice and a company like yourselves, especially around policies and kind of clearly defined responsibilities?
Yeah, I mean, like anything, taking it really simplistically, you say what you do and you do it, and we say what we do and we do it. And for governance, it's really important because of, taking a really simple example, but basic life support, for example, we as a company don't find it easy to put 10 sessions on, and get everybody trained. Actually, for us to ask PCNs to deliver that, and Oliver McGowan training, for example, those two, for examples, having those locally provided and in a contract to say, look, help us out here, this is your responsibility as much as ours, because it's a locally delivered clinical requirement for our staff to be on these mandatory trainings. So that's a small example, really. And, utilisation and commissions, we're not naive in thinking we need to deliver on what we're saying we deliver on, because it's a competitive market. We need to be, I think, gold standard is above 90% utilisation, X amount of contacts per week, whatever's in that contract we deliver on. And if we don't, then obviously we have a really strong operational delivery team within Promni that will flag anything that's an outlier, and then we'll have an action plan. We've got really robust governance management structures in place where we have a governance meeting once a month. We have SMT once a month. So any of these things that we're saying we're doing, issues that we're not providing what we're saying we're providing, we will bring up and create actions from those meetings that are drawn together.
Okay. Yeah, that's really helpful. So I suppose going along the timeline, then we've started a relationship. We've started having the clinicians in practice. So kind of once the service is established, how do practices continue to monitor the quality? So you talked about that briefly there within the SLA, but what's kind of the I guess the measuring sticks that you would use to determine success or not?
Yeah, I mean, at that point, once the service is embedded, we would expect to have ongoing service reviews. So I think it can be a little bit of a barrier, that actually the ongoing part, which we really try and mitigate by having those service reviews that are regular. And as we know, all of our diaries are busy, but because, for example, if we've put two FCPs in a practice and there's no management around that area, the team lead maybe doesn't live really close, it's how do we monitor? So there is a heavy reliance on working together as an organisation in conjunction with the local practice. So we would rely, knowing if there was any informal complaints, if there's any concerns, if there's any really good practice that was happening. So that ongoing relationship's really important. Our members of staff would always have supervision weekly, so
Okay.
we would always check in with them as well. So it's like a two-way thing, isn't it? How's your diary? How's your, whatever's usually on the clinical supervision, management supervision agenda, which the leads have. So I think having a really robust lead system in our organisation really mitigates anything, going wrong, if you like, but
Yeah.
also helping what's going right to make it really successful. And I think I already said, which I'll come back to, is having where it's really successful is where that relationship between ourselves, and we're not working in silo, but our members of staff are integrated as part of the MDT team. And
Mm.
let's face it, that's how neighbourhoods are going anyway.
Of
So
course. Yeah.
it's very rare now that I'm going into the future now a little bit, but it's very rare that one practice will employ all their own staff. It's going to be coming from different agencies or different organisations and coming together to deliver that neighbourhood care as MDTs in the future, in our huddles,
Yeah.
in the neighbourhoods. Yeah.
Yeah, I think we're already there actually to some
Well, yeah.
extent. Yeah, I think especially with the R's roles and everything like that within the PCN over the last 5 or so years. So I think that's really important. And that's really helpful because I was thinking as well when you were talking about earlier on about complaints, I started thinking about significant events. So touching base with and having those weekly meetings, you've got that platform to have those good conversations, have those bad conversations, but then that improves the learning. You can then report back, or the clinician can report back to the practice to show how they've reflected on it, and I'm saying all this. This is hopefully stuff that doesn't won't happen very often, but we live in the real world. These things go wrong. We're only human. And what I picked up from CQC is they will say, how do you evidence the quality improvement and learning together when things do go wrong? So, I'm really encouraged and I'm quite happy what you've said because it's so supportive of that environment.
And one of my passions actually is around learning from any incidents and reporting lower level incidents. So in my career, I've predominantly worked in secondary care trusts. Although I'm a physio, I've worked a lot in nursing and medical backgrounds as well. And actually, some of the research that I've done professionally is around the more lower level incident reports that you report, the more open the culture, the more free people feel psychologically safe to speak up, the less moderate to higher harm incidents that occur. So actually, yeah, I'm always advocating if there's an incident, there's no blame here. I'm very much around the no blame culture. I mean, we have a dedicated Freedom to Speak Up Guardian. Freedom to speak up is huge in preventing patient safety incidents. So, yeah, I mean, yeah, one of my things is making sure that we are in line with NHS England, with CQC, that we're doing the LFP FPSCs. We're aligned with PISA, even though it's not something that you do in primary care as a mandatory, but the whole patient safety framework from NHS England has to be followed. And yeah, it's always encouraged, and it doesn't just stop at the reporting. So it's that embedding of the culture of learning as well. Are we celebrating how we've learned from this incident? A recent example is around red flag reporting, and how you have to be really specific. That, say, cuts out on the missed tumours, the missed cauda equinus, and then sharing how has that been done, what's the case study, and we've just introduced after action reviews within the company as well, within our company. So everybody will get on a lunch and learn for 40 minutes on a Monday, and then somebody will present a case. And the feedback we've just got from that is brilliant. So yeah, it's the
Yeah.
learning.
That's the what do CQC call it? Closing the loop, isn't it? So something's
Closing the
happened
loop.
over here, you've talked about it, but how does everyone else over here hear about it? Yeah.
Exactly.
And I think the cultural element you spoke about, I know from a different setting, the criminal setting is the broken window effect. So if a window is broken, how is it then ever addressed? Is anyone brought to consequences for it? And it's sort of then, well, if the window isn't broken, then you go on to do something worse. And I think that's the same in healthcare.
I love
with
that
what you were
analogy.
saying.
Yeah.
So it's that culture, if you don't tackle the low level stuff, it might even seem insignificant. I hate that word in that context, but what does it lead to in a week, in a month, in a year, whatever. So, and that's when you look at the reviews, especially the when it's gone horribly wrong.
Francis report, the Ockenden, all of them.
It's all in there.
All in there.
So that's really interesting to hear that. So I think kind of as I look to wrap up then, what do you think makes that practice and provider relationship successful then over the long term? So we've done the introduction, we've done the short term. How do we sustain that for the months, years ahead?
Yeah. So alongside the initial point, which is the collaboration at local level, I think, without meaning to sound, it's communication, isn't it? So making sure that we're communicating back and forth with each other, that it's not in silo, that we're providing really frequent updates on our services, quality standards, quality outcomes are shared. I know that we've started doing quarterly reports so that we can show you things like utilization, DNA rates, audits, local audits that we've been doing. So I think to have a really successful relationship, it's not just the start and the middle, but it's really thinking to the future as well. So it's really thinking about actually how can we expand? And it's giving PCNs practices confidence in us as an organisation, and I would really hope that having a really robust recruitment and governance team and HR is a really, really reassuring aspect of a third party provider, especially with CQC, like all of those CQC standards that you have to adhere to. If we show we're adhering to as that provider, that is as good as reassurance as anything, I think, because there are staff. We have a great retention rate of staff. Yeah, there's so much that I could say, but yeah, I think that's how we put forward with a really good relationship. It's just teamwork, isn't it? It's like we have such a really robust governance and management team. I think for having a third party provider in a practice, I think that has to be the case, for that confidence in the service.
Yeah, and I suppose we talked a lot about the staff and the setting up, but where it comes back to the patients, I love hearing feedback when it's like, and it's so ingrained that it just becomes the norm to the patient. It's like you've always been there type thing, and there's no like, are they part of the practice or not? No, it's such and such a clinician, or the FCP, and it becomes embedded into the practice again from a patient level, but as well as a staff level. So I suppose one question I'm starting to ask: what excites you the most about the future of kind of integrated primary care services? So yeah, kind of you talked a little bit going ahead of neighbours and everything like that, but what's kind of getting you up in the morning? What excites you about the direction of travel at the moment?
I think it's really easy to look on the negative side of change, isn't it? Like I've done quite a lot of change management work in the past, and things are changing so quickly in primary care, secondary care as well, but primary care specifically. And I've been in primary care in this role now for almost 3 years, and things have changed quite rapidly in the last 3 years. So I think for me, it's because I've embedded a really good governance structure within our organisation. It's seeing that embedded. I think for us as an organisation and myself, getting CQC registration as a standalone company is really an exciting place for us at the moment. And the prospect of that, I think expansion, I think the NHS will continue to change and evolve over the next 3-5 years. I think the change in government, everything nationally with policies is changing so quickly. The world of AI is fascinating. It fascinates me. and how that will change things really considerably, not only at a national level, but a local level, a delivery level, service level, patients. All of that stuff is really exciting at the moment, and it's having to keep on the ball with everything that's going on politically, economically, and socially at the moment to be able to adapt to change. And I think, the expansion of our business at the moment in primary care is just an exciting place to be in the NHS because things are just going to keep on changing. So that's probably what keeps me up.
Keeps you going.
Excited about my work at the moment. You never know what's going to happen around the corner, do we? And obviously, in the neighbourhoods have been going on a little while now, and it's a little bit of, well, what does that mean? How is it working in practice? But we're almost at the what's next stage, aren't we?
Yeah, I think so. Well, thank you for sharing. That's a lovely note to end on today as well. And I think kind of in summary, general practice continues to work more closely with more and more external providers. And I think you've highlighted that the strong governance becomes ever so important within that. And it's not just built on the contracts alone. It's built on that trust, communication, shared values, and that collective commitment to delivering the safe, effective and patient-centred care. So I hope this episode has been helpful, especially if you're already working with third-party providers or looking to do so in the future. As I say earlier on, understanding that governance isn't just a compliance exercise, it's fundamental. So Catherine, thanks again for joining me today.
Thank you, Ben.
Thank you all for listening, and we'll see you next time at the Halfway Point. Thanks again.
Thank you.
Thank you for joining us today for another episode of The Halfway Point. We hope today's conversations has given you a fresh inspiration and practical ideas you can take straight back into your practice. You'll find all the links and resources we mentioned in the show notes at locumpm.co.uk. The Halfway Point is available on all major podcast platforms in both audio and video formats, so you can tune in however suits you best. If this episode helped you, we would generally love to hear from you. Leave us a review or a comment. Not only does it make our day, it also helps us shape future episodes around what matters most to you. Make sure you follow and subscribe so you do not miss next Wednesday's episode. And if you know a colleague who would benefit from this conversation, please share this episode with them. You can also connect with us on LinkedIn and Facebook by searching for the Locum Practice Manager. We're on YouTube too, where we share practical tips and tutorials for primary care managers. Until next time, keep moving forward, keep improving, and we'll see you again next week at the Halfway Point.